Thank you so much, Naresh, for your kind introduction. And good evening, dear my professional colleagues. This is Dr. Sepuri Krishna Mohan. I'm an endocrinologist at my own center, Sepuri Diabetes and Endocrine Center. So, I would like to start with a thanks to Boringer Ingelham for giving me the opportunity to be the speaker of this evening. So, today we are going to talk about the Linagliptin, per se, the brand of the Boehringer Ingelheim, the research molecule of Boehringer, and the brand name is Trasenta. It's available all over the world. A brief introduction to this particular DPP4 inhibitors. So then we'll get into the slides. So these are the drugs which act by inhibiting the DPP4 receptors actually. So there are several receptors like DPP8 is there, 9 is there, but they are not much related to the lowering of blood glucose. We are basically confined and concerned to only the DPP4 inhibition, which is going to reduce the blood sugar levels. So per se, the DPP4 inhibitors, the dipeptyl peptidase inhibitors, are called gliptins. Like we call the SGLT2 inhibitors gliflozins. See, we the term gliptins was coined by Novartis in association with the World Health Organization first. So the first molecule to get the approval of US FDA in this particular class of drugs, the gliptins, is the sitagliptin, which was given approval on October 17th of 2006. That was the first molecule to be approved by US FDA. So followed by the saxagliptin actually in the year 2010, and vildagliptin is not approved by USFDA as it did not submit the cardiovascular outcome trials, though it was a molecule which was a research molecule of Novartis, even discovered prior to this particular sitagliptin. So, as they did not submit the COVT, by then the sitagliptin captured the entire US market. And Novartis people thought it's waste introducing this molecule in US. So they basically concentrated on the other parts of the world like European Union and the Indian subcontinent and all, the Asian subcontinent, everything. So the approval for this vildagliptin was given by the European Union in the year 2007. So that is 1 year after the US FDA gave approval to sitagliptin. And out of all the gliptins, see, as a clinician, as an endocrinologist, to the best of my knowledge, I feel the linagliptin is the real renal gliptin, and that is the most potent gliptin that inhibits this particular DPP4 receptors to a tune of many a time than that of the sitagliptin or the saxagliptin or what so you call the vildagliptin. So this is the DPP4 inhibition is highest seen with this particular linagliptin. So linagliptin was approved by USFDA in the year 2011 actually. So with this, I'll tell you in the coming slides why I called it a real renal gliptin. Because the only gliptin, they say there are some peculiar characteristics of this particular linagliptin per se. See, this is the only the gliptin which doesn't require any sort of dose adjustments in the case of the diabetic kidney disease, any stage, any EGFR, and the even the diabetic liver disease, that is old terminology is NAFLD and NASH, that is the fatty liver on the ultrasound scan. We divide it into the non-alcoholic fatty liver disease and non-alcoholic steatohepatitis. And the International Society for Hepatology has changed the terminology very recently. It started calling it MAFLD, that is metabolically the associated defective liver disease actually, and the MASH, that is metabolically active the steatohepatitis. So the terminology is little bit changed, but don't get confused. So this has got a role in reducing this particular this events actually. So which doesn't require any sort of dose requirements. These two conditions. One is the kidney disease, and the second is the chronic liver disease. And the peculiar feature and the greatest aspect of this particular Linagliptin, yeah, I'm getting some echo. Please, would you mute yourself? The audience are. Please, please mute. All of you mute yourself. I'm getting echoes. Okay. Thank you so much. And this is the only DPP4 inhibitor which has got two cardiovascular outcome trials. The one is the Carmelina and the other end the Carolina. The Carolina was done with an active comparator for the first time in the world. Was done on the one arm it is Linagliptin and the second arm it was glimepiride actually. So the basic difference between these two COOTs is that the Carmelina was done with the maximum the patients with the maximum risk of cardiovascular disease, that is high risk for cardiovascular disease, were included in the Carmelina trial, whereas this particular the Carolina, the low risk group was included, the low risk cardiovascular disease group was included in the Carolina. So I think with this introduction, yeah, we'll get into the slides. Yeah, somebody is making lot of noise. Please, would you maintain some silence, please? Please. It's very disturbing and very annoying actually for the speaker. So today we are going to talk about a wonderful topic like the Linagliptin, and you start making noise. Doesn't look nice, please. Thank you. And just we'll get into the. And today's topic is the simplifying the type 2 diabetes mellitus management with Linagliptin. So we are today concerned only with Linagliptin, that is the brand of the Boehringer Ingelheim, the Trasenta. And the contents are divided into the management of the patients with type 2 diabetes mellitus, and mechanism of action and efficacy of Linagliptin, and safety of Linagliptin, and the cardiovascular outcome trials with Linagliptin, and the last part is summary. Yeah. Now, when managing the patients with type 2 diabetes mellitus, the treatment selection can be made complicated by a number of factors actually. You can clearly see the patient suffering from type 2 diabetes, and per se, I tell you once again, the oral drugs are only meant for the treatment of type 2 diabetes mellitus, never ever indicated in type 1 diabetes mellitus or the gestational diabetes mellitus or the other specific types of diabetes. This is very important, please. And the patient suffering from type 2 diabetes has got a lot of problems like the variable expectation of the efficacy, and the weight control is an issue, and hypoglycemia is the biggest issue, and monitoring the blood glucose levels, and the associated comorbidities like hypertension, dyslipidemia, even the coronary artery disease or the atherosclerotic cardiovascular disease or the heart failure or the strokes, and it goes on like the diabetic kidney disease and all. And cost is very important actually in the treatment of type 2 diabetes, especially a country like India where there is no comprehensive insurance policy system, where the patient has to take out money even for the consultation of the doctor, the investigations, and to purchase the medicines. The patient has to bear all the expenditure, and even though there is the insurance system, I think that is confined only for admissions, not for OPD basis. And polypharmacy is the another headache because lot of drugs are used for a case of type 2 diabetes mellitus. They might be like addressing the type 2 diabetes mellitus. He's got hypertension, he's got dyslipidemia, he's got the thyroid problems, usually the hypothyroidism, he or she. And then the patient might develop either the ischemic stroke, not the hemorrhagic stroke, and the atherosclerotic cardiovascular disease. So he might require antiplatelets and statin inevitably. So usually they have neuropathy. You need to address that, and at least you need to prescribe one the vitamin B12, that is the methylcobalamin, cyanocobalamin, to prevent the future effects on the neuropathy, because we always start with a metformin, and metformin all the time interferes with the synthesis of vitamin B12. So the list goes on like anything. And dosing and timing is also very, very important. These challenges are the most common reasons for resistance to changing the therapy. And this is the slide which shows the treatment algorithm of type 2 diabetes mellitus as per the American Diabetes Standards of Care 2024. Every year, the American Diabetes Association releases the guidelines, the ADA Standards of Care. So this year also, so every year, suppose it is 2024, it releases the guidelines in the month of December 2023 on the internet. So somewhere around 15th or 16th of December, you get the ADA standards of the care for diabetes, actually the medical care. And the first edition of diabetes care, that is there are two official journals of American Diabetes Association. One is the diabetes is exclusively for the researchers, and the diabetes care is the one that is very useful for clinicians. So the first edition, the January edition of the diabetes care consists of only the standards of medical care for that particular year. It doesn't contain any articles. Nothing is published other than the guidelines. So you can see the ADA standards of K 2024 recommend glucose lowering agents with the demonstrated cardiovascular benefit independent of the glycosylated hemoglobin, representing a shift in the treatment of type 2 diabetes. So on the right hand side, you can see the table, the use of the glucose lowering medications in the management of type 2 diabetes. And it says that among the patients with type 2 diabetes mellitus who have established atherosclerotic cardiovascular disease are indicators of high risk, that is established kidney disease or heart failure. An SGLT2 inhibitor or GLP-1 receptor agonist with demonstrated cardiovascular disease benefits is recommended as part of the glucose lowering regimen, independent of A1C, and in consideration of the patient specific factors. See, to tell you very honestly, forget about this 2024. See, the first international body which endorsed the usage of this particular the SGLT2 inhibitors or the GLP-1 receptor agonists, and at the time of diagnosis itself, that is a case of newly detected type 2 diabetes mellitus or the de novo type 2 diabetes mellitus, irrespective of the HbA1c, the patient is at risk of developing the atherosclerotic cardiovascular disease or the 3-point MACE, or this particular the heart failure, and the other class of drugs is the GLP-1 receptor agonist. So it said it can be used even without starting a metformin. You can straight away go to this particular group of drugs. One is the SGLT2 inhibitors, or the second is GLP-1 receptor agonist, irrespective of the baseline A1C. So the two criteria is the patient must be at risk of developing atherosclerotic cardiovascular disease, or by then you diagnose a case of type 2 diabetes, you must have an established cardiovascular, atherosclerotic cardiovascular disease or heart failure. So the drug of choice is the 3-point MACE is predominant, where atherosclerosis is very predominant. The drug of choice will be always the GLP-1 receptor agonist. And in case the patient has got the heart failure and the hospitalization for heart failure, which is very predominant, the drug of choice is SGLT2 inhibitor. And the European Society of Cardiology says, it said in 2019 itself, that if you combine both the drugs, the patient has got the maximal cardiovascular benefits. So then later on, in the later parts of 2019, the EASD, actually the European Association for the Study of Diabetes, joined hands with the European Society of Cardiology and started giving the joint consensus of the European Society of Cardiology and the European Association for the Study of Diabetes 2019, the guidelines, which say the same what I said. The GLP-1 receptor agonist, if atherosclerosis is predominant, the 3-point MACE is predominant, and the heart failure and the hospitalization for heart failure is predominant. The SGLT2 inhibitors, they play a vital role. And if you combine both these drugs, it has got a good synergistic effect, and it is very useful in preventing most of the complications, like the complications on the heart, the complications on the kidney, the complications on the liver, and whatnot. Even the serum uric acid also is, hyperuricemia is also to some extent is lowered by this SGLT2 inhibitors. So these SGLT2 inhibitors are called the pleiotropic drugs. The one wonderful pleiotropic drug we already know is, one is insulin, the second is the statin, the third is the metformin, and the fourth is the SGLT2 inhibitors. As far as our domain is concerned, the endocrine domain or the diabetic domain, see, that is basically, these are the pleiotropic drugs. And the same thing, that's what in 2022, 2023 and 2024, the statements they did not change actually. So moving on to the next slide. And you can see the graphic representation in this slide showing the reductions, the relative risk reductions of 38% in cardiovascular death and in the patients who are put on this particular empagliflozin. This is taken from the empiric outcome, which is the first the cardiovascular outcome trial for this particular empagliflozin, actually, which was approved by the US FDA in the first quarter of 2014. The canagliflozin was the first one to be introduced in the year 2013 by US FDA, followed by empagliflozin in the early months of 2014, the empagliflozin, and the last one was the dapagliflozin in the same year 2014. And there are several other gliflozins actually. The etugliflozin and ipragliflozin and sotagliflozin, and so many are later on approved by US FDA, but they are not available in our country. We have only per se, we have 3 gliflozins, like the SGLT2 inhibitors, the canagliflozin 100 milligram and 300 milligram, and empagliflozin 10 milligram and 15 milligram, 25 milligram, sorry, and the dapagliflozin 5 milligram and 10 milligram. Likewise, you have got so many the gliptins, the DP4 inhibitors, starting with vildagliptin, the sitagliptin, the saxagliptin, the Linagliptin, and the Allogliptin, and these are all they approved by US FDA. But as and today we have got though it is not approved by the US FDA, it is approved by European Union. We have got Vildagliptin, which is off patented, Sitagliptin from MSD, which is off patented, and Linagliptin is still not off patented, but okay, so companies have come into market like they have flooded like anything with Linagliptin actually. So, and Allogliptin also we have got, and there is one more called the Gemigliptin and the Evogliptin. So, we have got all these molecules, but out of which I said the real renal gliptin is the only thing is the Linagliptin. So, in empiric outcome trial, the reduced risk of cardiovascular death for patients with type 2 diabetes, established cardiovascular disease with empagliflozin was observed early and sustained throughout the trial. You can see the graphic changes in this particular the diagram. Actually, the blue is empagliflozin, that is, and the grey color is the placebo, that is standard care plus placebo. The number included were 2333, and the blue line represents the standard care along with empagliflozin, where 4687 patients were included, and you can clearly see the graphs getting separated from the beginning itself. That is, the moment you start this particular empagliflozin, you find a spurt in the graphs. The placebo is going up, and this is the not going along with the placebo, it is coming down. See the difference. See the wide at the end of the 48 weeks, actually, you can see the wide difference between the placebo and the empagliflozin group, saying that this particular empagliflozin group had 38% relative risk reduction in the cardiovascular death, which is for the first time was noted as a very beneficial effect, a pleiotropic effect, apart from its reductions in the blood sugars. The funniest part of this, the gliflozins, the empagliflozin and the dapagliflozin, they started as the glucose lowering agents. So the physicians and the diabetologists and the endocrinologists and all the clinicians treating this diabetes, they started thinking this is our own molecule. And later on, it started exerting all the beautiful effects on the heart, like reducing the 3-point MACE and reducing the heart failure and the incidence of the hospitalization for heart failure. And based on that, the cardiologist thought this is our molecule. And later on, seeing the renal benefits of this particular the empagliflozin, and the nephrologist said it is our molecule, and even the gastroenterologist, the pathologist started saying it is our molecule, as it has got a very favorable effect on the chronic liver disease. To start with is the fatty liver disease, and the end is the chronic liver disease. So I tell you that it is everybody's product, and this is the per se the patient's product. So which has got the lowering of blood sugar, lowering of blood pressure, and that results in favorable effects, especially in two conditions. One is the nocturnal hypertension, and the second is resistant hypertension. So it reduces the weight. It has got the cardiovascular benefits. It has got the renal benefits. It has got the liver benefits. So cardiometabolic, renal, hepatic continuum. This is the drug of choice. So the p-value is that is 0.001. That is that means it is statistically very significant. This the point which I said, the 38% relative risk reduction in the cardiovascular death. So moving on to the next slide. However, a need remains for additional glucose lowering agents with demonstrated glycemic efficacy and long-term cardiovascular and the kidney safety profiles. See, from 2008 onwards, the USFDA has made it very mandatory that any molecule that is to be used in patients suffering from diabetes mellitus, that is especially with reference to type 2 diabetes mellitus, should have the positive cardiovascular outcome. If not positive, it should be neutral to the cardiovascular events. It should not worsen the cardiovascular events. That is the reason it has made it mandatory that every molecule should have the satisfactory cardiovascular outcome trials before that is the USFDA gives approval to that particular molecule. So this is the essence of this. And now, of late, the USFDA thought all COOTs are not possible, and it has they taken out the mandatory COOTs, cardiovascular trials are not required, but subset of patients like 500 patients of CKD, the 600 patients suffering with the cardiovascular disease must be included, and so age group must be included. So it has put some criteria instead of cardiovascular outcome trials. If one can, the one a molecule can satisfy all these criteria, USFDA gives the approval. And this slide shows the DPP4 inhibitors are a common treatment option for glucose lowering in patients suffering from the type 2 diabetes mellitus. And the characteristic features of this particular drugs, the DP4 inhibitors, the gliptins, it should be like it should be weight neutral, the first the quality of any drug, and it should be having very less incidence of hypoglycemia, especially the nocturnal hypoglycemia, especially the level 3 hypoglycemia. And the drug should be well tolerated by all age groups, and it should have a long experience actually. So moving on to this again the graphic representation of linagliptin, which shows that linagliptin has got the highest DPP4 inhibition potency compared with other globally available DPP4 inhibitors. See the violet one on the left hand side is the linagliptin, and all others are the allogliptin, the sitagliptin, the saxagliptin, and the vildagliptin. You can very clearly see the curve of linagliptin, the graph going down and down, showing the high potency of the linagliptin in inhibiting the DPP4 enzyme activity. So this is to say that linagliptin is the most potent DPP4 inhibitor available in the basket of gliptins per se. And there are other gliptins which I said that they are not mentioned here. The evogliptin or the gemigliptin, there are so many, but they are not mentioned here. And you can see the selectivity of DPP4 inhibitors in this slide. You can see the sitagliptin and the vildagliptin and the saxagliptin and allogliptin and the linagliptin. You can see the figures which clearly show that not only on the DPP4, DPP2, and it has got the effect on the DPP8 and DPP9 also, but it is a $1 million question whether the DPP8 inhibition, the DPP9 inhibition is significant in the context of reducing the blood sugars. So some studies have suggested that DPP8 and DPP9 may be implicated in the preclinical toxicities and suppression of the T cell activation of proliferation. Because these are present, the DPP8 and the DPP9 receptors are more present in the heart muscle actually. And this is the slide which justifies my statement that linagliptin is the real renal gliptin, which doesn't require any sort of dose modification in any stage of the clinical the diabetic kidney disease classification, or the classification based on the estimated glomerular filtration rate. So even the clinical or the EGFR, it has got 5 stages. and 1, 2, 3, 4, 5, and 3 has got EGFR based classification, has got stage 3A and stage 3B. The linagliptin is the globally available DP4 inhibitor with the lowest kidney excretion rate actually. So 5% of the linagliptin is excreted through kidney. That is the reason we don't require any sort of dose titration during ESRD or ESKD, that is end stage renal disease or the end stage kidney disease, or it can be used along with insulin during the dialysis. It can be used even the post dialysis. It can be used during the transplant, kidney transplant, and a special entity called there is the new onset type, the PTSD, the post transplant PTDM, that is post transplant diabetes mellitus. That's a new entity. That is a new onset the diabetes which comes after transplant, maybe kidney transplant, maybe lung transplant, maybe heart transplant, maybe liver transplant. That is a separate entity. In that case also, along with insulin, if it is required, you can use linagliptin without any hesitation, without any dose titration. And you can see the sitagliptin 87% it is excreted through kidneys, and vildagliptin 85%, and alogliptin 76%, and saxagliptin 75% respectively is excreted to the kidneys. And dose adjustment is required in patients with kidney impairment in all these drugs, the sita, vilda, and the allo and saxa. We need to reduce this sitagliptin from 100 to 50 and 50 to 25. At one point, you need to stop. So the saxagliptin, the 5 milligram to start with, you have to come down to 2.5. Like Vilda, you can start with 50 milligram BD, you have to come to 50 milligram OD. So likewise, you need to titrate the dose based on the EGFR, the staging of the diabetic kidney disease, but the exception being the linagliptin, where you don't require any sort of dose titration. So this is the real renal gliptin. And this slide shows the linagliptin does not require dose reduction based on the kidney function. That is, I said, the diabetic kidney disease or the chronic kidney disease is divided into 5 stages. Actually, the anything above 120 ml per minute of EGFR is considered normal, and 90 to 120 is called stage 1 chronic kidney disease or stage 1 diabetic kidney disease, and 60 to 89 of the ml per minute of EGFR is called the stage 2, and the 45 to the 59 ml per minute of EGFR is called stage 3A DKD, and from 30 to 44 is called stage 3B, and anything from 15 to 29 ml per minute of EGFR is called stage 4, and the EGFR of the below 15 is called the end stage renal disease or the end stage kidney disease. So you can clearly see that the linagliptin, all the stages, it is used in the dose of 5 milligram without the down titration. Whereas all the other, I said, the sitagliptin and the saxagliptin and the vildagliptin and alogliptin, they needed the dose requirement, and at the stage of ESKD, you need to stop all the other gliptins. You need to put the patient only on this particular insulin and linagliptin per se. When kidney function declines, there is no need for DPP4 dose adjustment with linagliptin. That is the take-home message. And the DPP4 inhibitors, the clinically relevant pharmacological characteristics, you can clearly see that the DPP4 enzyme binding affinity is highest with linagliptin. You can clearly go through the table given, the saxagliptin, the sita, and the teneligliptin, and the Indian gliptin, teneligliptin. And my suggestion is, please, you got off patented vildagliptin at a very affordable price. and off-patented sitagliptin at a very affordable price. Please avoid teneligliptin because it has got the tendency to increase the QTC. That is, the QTC in the ECG is prolonged. So please avoid teneligliptin. And many a time I've seen the clinicians writing teneligliptin BD, that is 20 milligram in the morning, 20 milligram in the night, along with metformin, which is a crime actually. So you are not supposed to use this teneligliptin twice a day, which further worsens the QTC prolongation that leads to arrhythmias, dangerous arrhythmias, and sudden cardiac death. So please don't make the patient die miserably just because of our ignorance. So the take home message is the dosage adjustment in renal impairment is not required with linagliptin. So also the hepatic impairment, the dosage adjustment is not required with linagliptin. And let us come to the clinical efficacy of linagliptin in patients suffering from the type 2 diabetes mellitus. So this is the bar diagram which shows linagliptin demonstrating the efficacy in the patients suffering from type 2 diabetes mellitus. See, the placebo, it reduced the A1C, HbA1c by 0.4%, whereas the linagliptin has reduced the HbA1c by 1.2%, which is the huge difference actually. See, that is 0.8% is the difference, and the p-value is 0.0001, which means it is statistically very significant. So the reductions in the A1C is much better with linagliptin. And the glucose lowering efficacy of linagliptin is similar to that of the other members of the DPP4 class actually. So the most the potent one which decreases the A1C by 0.75 is sitagliptin, and followed by the linagliptin 0.74%, and the allogliptin also the same 0.74%, followed by the vildagliptin 0.67% reduction, and the saxagliptin 0.61 the reduction respectively. And this when this comparison comes, see, I would like to suggest my professional colleagues that there are certain side effects with saxagliptin and this particular allogliptin. You have to be very cautious whenever you are using saxagliptin and allogliptin in patients who are at risk of developing heart failure or who have got the established heart failure, because these two drugs, especially the saxagliptin, is documented to worsen the heart failure or to precipitate the heart failure. So try to avoid saxagliptin and allogliptin. You can use, you want to use, you can use vildagliptin, or you can use sitagliptin, because sitagliptin is the TICO study, the robust cardiovascular outcome trials, which showed the neutrality, cardiovascular neutrality at least, whereas the linagliptin showed the positive cardiovascular outcome trials. So even when compared to the reductions in the A1C with the other competitors also, it stands first, okay, along with the sitagliptin, a very statistically insignificant difference of 0.01. And the linagliptin demonstrates efficacy across a broad range of diabetes therapies. The adjusted mean HbA1c change from baseline and the placebo corrected actually. So you can see on the left hand side the bar diagram shows when the linagliptin is used as monotherapy, and next is followed by the dual therapy, and next is the triple drug therapy, and the next is add on to this the existing oral drugs, adding the basal insulins. You can clearly see that the reductions in the A1C respectively, the monotherapy is 0.69%, and with metformin it is 0.60, and in the Japanese population it is 0.87. And the take home message of this entire slide is that when compared to the Caucasians, the white people, either the Europeans or the Britishers or the Americans or the Canadians or the white people, the Caucasians, the blacks, what they call as the Asians, the black, the Asian people have got better DPP4 inhibition when compared to this particular the Caucasians whites. So they have got less A1C reductions when compared to the Asian population, wherein these DPP4 inhibitors they exert a significantly different reductions in the A1C levels. So much A1C reductions are seen in the Asian population, starting from Japan to the India, the China, and all the Pakistan, Bangla, and all this the Philippines or the Korea, North Korea, South Korea, all the Asian countries, they have got a better DPP4 inhibition. And also it is same with this SGLT2 inhibition also when compared to the Caucasians. In the Asian population showed a good reductions in the A1C when compared to the whites actually. So, Linagliptin demonstrated a significant A1C reductions in the patients with the different ethnic backgrounds. See, you can see in this particular bar diagram, and this shows the adjusted mean A1C change from baseline at week 24 actually. So after 4 weeks. So the first one is the black and the African American. So the second is Asian, and the last one is the Hispanic actually. So you can very clearly see this. The black and the African Americans, the placebo is 0.25, whereas this particular the Linagliptin had shown reductions by 0.84, and in the Asian population it is 0.18 in the placebo and 0.68 with the Linagliptin respectively, and the Hispanic it showed 0.05 the placebo and 0.63 in the Hispanic group actually. So the Linagliptin demonstrated significant A1C reductions across all the age groups. You can see the below 50 and 51 to 65, 65 to 75, and above 75. You can clearly see the reductions which are very similar, that it has got a good quality, that it reduces the blood glucose levels and the HbA1c very like the very slow fashion, so that the patient doesn't get into hypoglycemia, especially the nocturnal hypoglycemia. So it can be used very safely in the elderly people, where that is the per se the definition in our country is around or above 75 is called elderly patients, and it can be safely used either the below 50 and the above 75 is also with the same reductions in A1C with no hypoglycemia. So it can be safely used in all age groups. So Linagliptin demonstrated efficacy in patients with a long history of type 2 diabetes, that is even more than 10 years of duration of diabetes actually. On the left hand side you can see this the graphic representation, and the right hand side you can see the bar diagram where it shows the difference between the placebo and the Linagliptin. The percentage of patients achieving target A1C is around 36.8 in the placebo, whereas it is 62.5% in the Linagliptin group, and the 21.1 and 47.5 respectively, and 10 and 11.8 respectively in the placebo compared with the Linagliptin group actually. So the long-term glucose lowering efficacy of Linagliptin is comparable with that of glimepiride actually. This is what the Carolina trial shows. The adjusted change from the baseline A1C over time, that is the baseline A1C was around 7.31%, and the violet one is Linagliptin plus metformin, and the orange one that is glimepiride with metformin. So The baseline at the end of the 104 weeks, actually it was a long trial of 5 years. So it showed 0.6% at the week 104 with linagliptin, and it was comparable to that of the efficacy of glimepiride at the end of 5 years. The only difference was the linagliptin arm showed the very less weight reduction. It was almost weight neutral, whereas the glimepiride arm, it showed plus 5 kilos weight gain. And the second thing is the hypos were not at all significant in linagliptin arm, whereas the significant hypoglycemias, even the level 1, level 2, level 3, and the nocturnal severe hypoglycemias were noted with the glimepiride in this particular Carolina, the cardiovascular outcome trial. And with linagliptin, more patients achieve target HbA1c levels without the hypoglycemic events or weight gain compared with glimepiride. That's what I said. You can see the bar diagram wherein it shows glimepiride plus metformin in the orange one, and the violet one shows the linagliptin plus metformin. You can clearly see that the proportion of patients achieving HbA1c and the proportion of patients achieving HbA1c target less than 7 after 2 years, and without hypoglycemic events, and without weight gain. That's what the difference is between the glimepiride arm and the linagliptin arm. Only two parameters were noted at the end. The less the weight gain, and it was almost neutral, and the incidence of hypoglycemia is very low in linagliptin, was very high in glimepiride. We know that. Okay. The efficacy of linagliptin remains consistent across all stages of kidney function. The adjusted mean HbA1c range from baseline versus placebo to degree of kidney function. You can clearly see from normal to the mild kidney impairment to moderately kidney impairment to severe kidney impairment. This is the clinical classification, and you can clearly see that the linagliptin they were used the HL these are all the long acting gliptins, except this particular vildagliptin, which is to be used twice a day, 50 milligram BD. All gliptins are once a day, apart from the vildagliptin. And now also the Indian formulations have come out with a sustained release, that is 100 milligram sustained release of vildagliptin, which has got many studies showing that it has got the equal bioavailability when compared to the 50 milligram used BD actually. And the linagliptin demonstrates the significant A1C reductions in patients with type 2 diabetes and the hepatobiliary disorders. You can clearly see that, okay, this is between the difference between the placebo and the linagliptin actually. And with the hepatic disorders, you can clearly see the difference, and without hepatic disorders also you can see the clearance. It is there is no much difference actually. It is 0.75 with hepatic disorders and 0.78 reductions in the A1C, even where there is no hepatic disorder. So that's what I said. In the cases of the chronic kidney disease or diabetic kidney disease, you don't need any dose titration as far as linagliptin is concerned. Likewise, the hepatobiliary disorders also, the chronic liver disease, you don't require any dose titration. You can start with 5 milligram linagliptin, stay with 5 milligram all through. You don't need to worry about the adverse events. And linagliptin, the one dose once daily for patients suffering from type 2 diabetes mellitus, and the 5 milligram once daily linagliptin is independent of the age, the disease duration, the background of type 2 therapy, and the kidney function, and the body mass index, and the ethnicity, and the liver function. These are all the positive effects of this particular linagliptin, that is independent of all the risk factors. The 5 milligram once daily linagliptin. And coming to the safety of linagliptin in type 2 diabetes. So the linagliptin demonstrated the significant HbA1c reductions without hypoglycemia in older patients with type 2 diabetes on stable insulin therapy. You can clearly see that the A1C of less than 8%. You can on the left hand side, you can see on the right hand side the A1C of less than 7%. See the people achieved the less than 8 is around 41.4% with linagliptin when compared to the placebo it is 28.7, and respectively the less than 7 of HbA1c, the 23.1% of linagliptin versus the placebo 12.5 respectively. And now coming to the cardiovascular outcome trials and the CV and the renal outcomes with DPP4 inhibitors, the linagliptin is safe across all cardiovascular and renal outcome trials. So these are all the multiple the cardiovascular outcome trials. The SAVOR TIMI 58 is done with saxagliptin, and TCOS is done with sitagliptin, and the Carmelina is done with the linagliptin. So you can see the parameters, and the red shows increased risk actually. So as far as the heart failure is concerned and the hospitalization for heart failure is concerned, I told you saxagliptin has got a tendency to increase the risk of hospitalization for heart failure or the precipitation of heart failure. So it is given in the red danger mark. It should be avoided. So there is limited evidence as far as renal outcomes is concerned, as far as the sitagliptin and the saxagliptin, and it is yes with all the parameters like the hospitalization for heart failure, the cardiovascular death, and 3-point MACE and the renal outcomes all are positive with linagliptin as shown in the cardiovascular outcome trial Carmelina. And I told you vildagliptin has no CVOT. It doesn't mean that it doesn't have any CVOT. It has CVOT, but they did not present it to ESFD for approval. See, the one trial is there that is called Vivid trial. Always remember VI that is Vivid trial shows that this particular vildagliptin is associated with increased left ventricular lung volumes, which may be a precipitating risk factor for the forthcoming heart failures. So you have to be very cautious. And teneligliptin, nothing to talk about teneligliptin. Why the mentioned in this teneligliptin, no CVOT. This is the Indian gliptin, and the risk I told you, it prolongs the QTC interval, which leads to the dangerous arrhythmias and SCD, that is called sudden cardiac death. So please stop using teneligliptin. You can use any other gliptin, like you can use vildagliptin is off patented. It is available at the 50 milligram at 5 rupees, or then 8 to 10 rupees the 100 milligram. So also 10 rupees you get 100 milligram of sitagliptin, and you can use this particular the linagliptin, the best gliptin, which is available at I think 15 rupee 90 paisa. The original manufacturers also have reduced the price actually. So and they comparing the Carmelina and the Carolina, they constitute a unique and comprehensive cardiovascular outcome trial program demonstrating the long-term safety profile on the linagliptin. On the left-hand side, you can see the Carmelina on the top and the Carolina in the bottom. And it's a randomized, the Carmelina is the randomized double-blind placebo-controlled. The patients with established cardiovascular disease and the or the CKD. So the duration was 2.2 years actually. And coming down to the Carolina, and both the groups, the Carolina included around 7,000 patients, whereas the Carolina included 6,000 patients. So randomized double-blind unique active comparator, that is glimepiride, and patients with relatively early type 2 diabetes, they increase cardiovascular risk. So that's what I said. The difference between Carolina and Carolina is the high cardiovascular and the kidney risk patients were included in the Carbolina, whereas the low cardiovascular risk group was included in the Carolina, and this was done a period of 6.3 years. That was the longest duration. And on the right hand side, you can see the mix up of the Carmelina and Carolina, showing the robust cardiovascular outcome program, demonstrating the long term safety profile of Linagliptin in two independent cardiovascular outcome trials for a broad range of patients with type 2 diabetes mellitus. So this clearly shows the safety profile of this particular linagliptin. And the learnings from Carmina trial, the risk reduction for albuminuria with linagliptin, you can clearly see that the 14% the lower risk of progression to albuminuria is seen on the left hand side, the graphic representation when compared to the placebo. And the right hand side, you can see 15% greater likelihood of significant regression in urinary albumin creatinine ratio. Now, the term microalbumin is replaced with a term called USCR, urinary albumin creatinine ratio, by the American Diabetes Association. You can clearly see the reductions the 14% relative risk reduction in progression to albuminuria. So also the 15% significant regression in USCR and the patients who are on linagliptin. And this is from the European Society of Cardiology, the glucose lowering treatments of patients with heart failure and type 2 diabetes. And you can clearly see that to reduce the heart failure related outcomes in all patients with T2DM and the heart failure. Heart failure may be the heart failure with a preserved ejection fraction, heart failure with a mildly reduced ejection fraction, and the last one is heart failure with reduced ejection fraction. There were only two in the beginning to start with, HPF and the HRF. That is the heart failure with preserved ejection fraction. That is, say above 50 and below 60 is called HPF. Whereas the below 40 is called this particular the HRF, that is heart failure with reduced ejection fraction, and from 40 to 50, that is called the mildly reduced, that is HPF with mildly reduced ejection fraction based on the left ventricular ejection function actually. So the SGLT2 inhibitors can be used independent of HbA1c, independent of concomitant glucose lowering medication. That's why I said whether you use metformin or not use metformin, that doesn't matter. You need to use this particular SGLT2 inhibitor. For additional glucose control, the other glucose lowering agents with the neutral effects on the heart failure and cardiovascular outcome trials should be considered, like the GLP-1 receptor agonists are the sitagliptin, the linagliptin, and the metformin, and the insulin glargine, and the insulin degludec. The other glucose lowering agents with increased risk for heart failure hospitalization in cardiovascular outcome trials are not recommended. That is especially the TZT, thiazolidine that is the only one that is available is the pioglitazone. I don't want to say anything about lobeglitazone, but okay. But saxagliptin, I said these two cannot be used where there is a risk of developing heart failure in any form. And one more thing, you're not supposed to mix up insulin with this particular pioglitazone also, which proves very lethal. That leads to a volume overloaded state, which suddenly precipitates the heart failure. So, along with insulin, never combine a glitazone, that is pioglitazone. Very, very important take-home message. And the beautiful aspect of this DPP4 inhibitors, the gliptins and the SGLT2 inhibitors, the gliflozins, they can be combined with any class of drug of the oral anti-diabetic drugs or the injectable anti-hyperglycemic drugs like the GLP-1 receptor agonists or the insulins, and the oral drugs starting from metformin to this particular pioglitazone, the alpha glucosidase inhibitors, the oglibos and all, acarbose, and can be used with this pioglitazone, any class of drug, you can add this particular either the DP4 inhibitor or the GLP-1 receptor agonists actually, and the gliflozins. There is no contraindication. There is no drug to drug in the interactions also with this DP4 inhibitors, gliptins, and the SGLT2 inhibitors, the gliflozins. And you can clearly see this which is given in the green box actually, and you can clearly see this particular not to be used, and on the top to be used actually. So linagliptin and sitagliptin can be used, whereas saxagliptin is to be avoided, and some studies have shown that even allogliptin is to be avoided to be on safe side. And this shows the inappropriate renal dose adjustment of the DP4 inhibitors in association with the poor clinical outcomes in type 2 diabetes mellitus. And this is taken from the Korean National Database, and the 82,000 odd patients with type 2 diabetes and chronic kidney disease were taken, and inappropriate doses, 1 out of 3 patients on DPP4 inhibitor overall study shows inappropriate dosing of in individual agents. 2 out of 5 patients are on sitagliptin, 1 out of the 4 patients on vildagliptin, and no patient on linagliptin. And the clinical outcomes with inappropriate dosing of the DP4 inhibitors on the right hand side, you can see the hazardous effects. The all-cause mortality was reduced by that was increased by 11.5%, where the p-value is 0.04. That is, though not statistically very significant, it is statistically significant. And the incidence of severe hypoglycemia is increased by 19.2%, where the p-value is 0.005, that is statistically very significant. And the ER visits, that is the emergency room visits, was increased by 7.4%, where the p-value is 0.009, that is statistically very significant. So this the right hand side, the difference between the left hand side shows the appropriate usage of linagliptin in the patients suffering from type 2 diabetes mellitus with comorbidities or without comorbidities. And of late all the companies have come out with the combination of glimepiride, metformin, and sitagliptin. So that has got some advantages. Okay, you can reduce the polypharmacy first, so that the attenuates the pancreatic, and it has got a mechanism which is still not explored and not explained, but it leads to the proliferation of the beta cells, they say. I'm not saying that. Okay. And the linagliptin, 1 dose and once daily for patients with type 2 diabetes mellitus. And we have seen this, the 5 milligram once daily is independent of the age, disease duration, and the background, the T2DM therapy, the kidney function, and the BMI, ethnicity, and liver function. And coming to the last part of this slide, actually, the take-home message summary, why we should use this particular linagliptin. So I've told you already very elaborately that first point is it has got the highest DP4 inhibition in its class of gliptins, the basket of the gliptins. Linagliptin has the highest DP4 inhibition. And second thing is, like all the gliptins, like all the gliflozins, the Indians have got a greater reductions in the A1C. The Asians, especially the Asians, all Asians and Indians also have the greatest reductions, and even the blacks, that is the African blacks or the American blacks, that is American Africans, they also have the greatest reductions in the A1C because of the better DP4 inhibition and better SGLT2 inhibition. And the HbA1c reduction levels in line with other DP4 inhibitors, and unique convenience, that is always 1 dose and once daily. That's it. 5 milligram. You start with 5 milligram. You maintain with 5 milligram and keep monitoring the kidney function. You need to inevitably, like as per the recommendations given by the American Diabetes Association, at least it should be done. The once in a year you should do lipid profile. Once in a year you should do the kidney function test, and once in a year you should take the 12 lead resting electrocardiogram, and once in a year the fundus examination. See, apart from the once in 6 months A1C and the microalbumin, that is USCR, and I suggest if the patient has no problem with the money, you can take A1C every 3 months, so that you can periodically monitor the A1C, so that you can change the treatment modalities or titrate the dose as per that A1C. And efficacy and safety data available in a broad range of patients actually. And the only DPP4 investigated in two cardiovascular outcomes, I said, that is Carmelina and the Carolina. And comparing the first time, it's an active comparator was glimepiride was compared with that of Linagliptin, and it demonstrated cardiovascular profile in large outcome trials actually, and there is no increased risk of heart failure or hospitalization for heart failure actually. And the final point is the only DPP4 with inhibitor with demonstrated kidney safety profile in the large outcome trials. And thank you so much for your patient listening. And if you have any questions or queries, please type in the chat box so that I can answer all your questions and clarify all of your doubts, please.